obesity as an important causative agent for cirrhosis.
How does a liver look in a fatty liver?
It's the difference between a good-looking angel and a very scary demon.
This was a 50-year-old gentleman. He came to me. He wants to get a screening colonoscopy. He says, I go to the bathroom once in 2 days. We did a colonoscopy. It was a huge cancer right at the rectal area. It turns out that the cancer was spread to the liver, spread to the lungs.
Oh, bad.
It was a stage 4 colorectal cancer. He passed away. I'll never ever forget that patient because he's a software engineer working in I can say the company.
And I believe, Dr. Pal, it's purely because of food habits.
Let me tell you a research we did in US. We figured out that the quality of life being compromised from a cancer patient is almost equal to an IBS patient.
But at least they have life.
Correct.
That textbook says, it's very vivid in my memory, the best way not to have cancer is not to be born at all. But also as a human being, I fear for cancer than any other disease, including heart attacks and stroke.
Constipation is a symptom that we should take it seriously.
I'm worried about constipation all the time. Not that I have constipation, but just we should rule out the cancers in every patient which I see. Probably you are a star student. Probably you would have understood it at the time. I never understood biofeedback then in my MBBS days.
Before we dive in, can I be honest with you? It blows my mind that 57.9% of you who listen regularly still have not subscribed to our channel. If you enjoy the podcast, the stories, the science, maybe even laugh at our jokes, could you do us a small favor? Hit that subscribe button. It takes only 2 seconds and helps us keep bringing you better guests and episodes every week. I'm truly blessed to have all your support and I'm sure you will support me in the journey. Now, let's get into today's episode.
Welcome to another episode of our podcast, Gut Feeling with Dr. Pal. In this episode, I'm interviewing surgical gastroenterologist Dr. Senthilnathan. So he's a director and chief surgeon in GEM Hospital, Chennai. In this episode, we are discussing about gut health and cancer risk and mainly about constipation, bowel movements, what is normal bowel habits, what is irritable bowel syndrome. If you're dealing with constipation, what are all the things that you can actually do, including a special technique called biofeedback. I think it is a wonderful, wonderful podcast. At the end of the conversation, I'm sure that you will get some take-home points to be executed on your day-to-day practice. Let's dive deep into it. Welcome, sir.
Oh yes, good evening. How are you doing, pal?
I'm doing good, sir. I'm doing good. I'm so happy to have you on my podcast. So the idea of this podcast is to educate people about gut health.
Oh yes.
One of the main thing I see as you as an expert is in your surgical oncology field, where you deal with so many cancer patients. In your practice, do you think the cancer rates have gone up in the last decade?
Absolutely, pal. What I see is the cancer doubling time is coming down. Previously, the incidence of cancer which doubles, we call it as doubling time, incidence doubling time is about 20 years.
So what is doubling time, sir?
Doubling is cancer incident doubles itself. Say 5% of cancer becomes 10%. For that to double, it takes about 20 years. Any cancer, lung cancer, breast cancer, stomach cancers, it doubles up in a reasonable over a long period of time. But what happens now is that cancer incidence doubling time has drastically reduced. Previously, it's about 20 years. Now it's less than 10 years. That means every 10 years, you see double the amount of cancer patients in each cancer, whether it is stomach cancer or any other cancer. So that's a very worrying trend. And I can say we as, at least from Indian point of view, I can say that we have moved from communicable disease predominant public to non-communicable diseases like hypertension, diabetes, and the cancer.
So you are a pancreatic cancer specialist as well. As a matter of fact, you are my senior in PhD Medical College, and I'm so proud to have you as my senior because you are one of the surgeons who actually do laparoscopic complex procedure called Whipple, where you remove majority of the pancreas organs and surrounding it. Do you think obesity increases the risk of pancreatic cancer?
Yes. Obesity has negative influence on majority of the cancers of the abdomen, starting from stomach on to pancreas, liver. See, fatty liver, from obesity to fatty liver to cirrhosis and then cancer. It's a common pathway. The one common, I would say, the axis of evil is obesity.
So
There are multiple axes of evils as far as the cancer-causing agents, like smoking, drinking. Previously, you used to have somebody smokes, somebody has drinks. They are bound to have cancer, isn't it? Now, definitely we can add to that evil obesity as well, without any doubt.
So tell me an example where obesity could have been caused the liver cancer in your experience.
Oh, yes. See, previously, when we talk about liver failure, I'm a liver, HPB, liver pancreas specialist.
So to educate the audience, he is a liver, pancreas and biliary tract cancer specialist. He is a surgeon. So he sees a lot of patients who have spread liver, who has liver cancer or cancer somewhere else spread to the liver. So in your experience, educate the audience, a patient that you might have seen where a liver cancer might have come unexpectedly.
See, that's why in liver cancer, 75 and 80, up to 80% of liver cancer happens in a cirrhotic background. Meaning, liver would have shrunken because of various factors and then the tumor pops out because the entire liver is carcinogenic. There are a lot of nodules which can turn into cancer. Previously, it's all about hepatitis and alcohol, which was the main cause for cirrhosis. Having said, now I can add along with the alcohol and the hepatitis B and C, obesity as an important causative agent for cirrhosis. Previously, it's very rare. Now, cirrhosis, yes, somebody I have to think whether he is not only alcoholic, not only a hepatitis carrier, but also an obesity. So, obesity up to 20-30% of the cirrhosis now in some countries are because of obesity. It starts with NASH, it starts with fatty liver, liver swells up initially, and you have seen fatty liver. We have conducted very big population studies, and Dr. Pal, you will be startling to know up to 60% of public are suffering from fatty liver.
Wow, more than 1 in 2.
Oh, yes.
Wow.
So that's a very mind-boggling statistics. Not all, I meant to say not all will have cirrhosis, but quite a good amount of percentage. Imagine numbers, in sheer numbers, crores of people are having fatty liver. Even few percentage turning into cirrhosis is a big thing. And then in that cirrhosis, whether it is from alcohol background or hepatitis background or from obesity background, it doesn't make any difference.
Educate the audience, what is cirrhosis?
Okay. So the cirrhosis is the end stage liver failure. Initially, the liver swells up, we call it as fatty liver. Then it loses its function and then it shrinks in size. That's the point all irreversible damage occurs. So as it progresses, it shrinks further and further so that at that point, the cancer pops out. Cirrhosis is the end stage of all liver failure, whether it is fatty liver, obesity, hepatitis or alcohol. So it doesn't differentiate. So obviously we are in a common pool where you are bound to have liver cancer. Treating liver cancer in a shrunken liver is very challenging than in a normal liver. So I can knock off 60-70% of liver without any problem.
Can you educate what do you mean by knock off?
Okay. If somebody has a liver cancer and if I want to remove 60% of the liver from our body, still 30-35% of the liver which we leave behind is quite good enough for us to grow. In about 2.5-3 months time it grows. That's the basic for all the liver transplant, when we take out half of the liver from a normal person and then give it to the needy. But in a cirrhotic background, that means when the liver is shrunken and then done and outdated, even removing 20%, not even leave alone 20, even 5-10% if you liver, the patients cannot cope up because already they are not coping up with the entire liver. Even you just pinch a small bit of liver, still it hurts us. So that's the regenerating capacity. In a normal liver, you can afford to lose 2/3 of the liver. In a shrunken liver, in a damaged liver, even pinching of a liver tissue will harm you. That's where the liver cancer treatment becomes difficult.
You open up the abdomen on many patients, or you do laparoscopic. How does a liver look in a fatty liver?
It's a difference between a good-looking angel and a very scary demon. A smooth, sharp-edged liver is a normal, healthy liver. Very rough, shrunken, lot of undulations. You see small dots on it. It's all very rough. That's a shrunken liver. It's for us. You all know. You also would have seen. It's not a very pleasant feeling even for doctors because of shrunken liver. So it's a smooth, sharp edges, good one. Very rough with blunt edges, that's a bad liver.
It's bad. So the point here is that fatty liver, please take care of yourself, because obesity, if you can control it, you can prevent it from progressing to cirrhosis. So moving on to gut health and other cancers. And one of the most important cancers I deal with, colon cancer. Is colon cancer rates increased in your practice?
Yes. Pal, we were all, I can say 90s kids. Correct?
Yes.
When we, probably I can say a little bit older, but we all graduated.
You look like an 2000 kids, sir.
Thank you for the compliment, but I'll go happily.
Yes.
But having graduated in our medical school in 90s, I can say that colon cancer was predominantly a disease of the West, where in US you would have seen lots of colon cancer.
Correct.
Every fourth or fifth patient you see with over 60, 70 years has have colon cancer. Same with Europe also. In India, at the time, fortunately, we were having low incidence of colorectal cancer. It was all more of a textbook disease. See, some diseases we have seen, day in and out we have seen. Some diseases we have read only in textbooks. One such thing is in colon cancer, where we have read predominantly textbooks. We see one here and there. When I finished my MS, I could see a little bit more of colon cancer. But I went into practice after my super specialization in surgical gastroenterology. I was astonished by the fact in about 20 years' time, it has totally tipsy-topsy, so that you see more of colon cancer.
Wow.
And I believe, Dr. Pal, it's purely because of food habits.
Food habits.
Purely. Refined foods, high calorie intake, red meat. So whatever we follow Western culture, probably about the 20-30 years behind. So that's why they caught up with the colon cancer early, and we were following now, and we are reaping all the ill effects of having these kind of food habits, I would say. It's a sorry state of affairs, but of course, yes, colon cancer is phenomenally increasing in our country.
As a surgical gastroenterologist, will you accept to the statement that red meat increases the risk of colon cancer?
Yes, I definitely agree. I would not say that's the only reason, but definitely that's one of the main reasons. See, you and me, during our childhood, our food habits were drastically different than what we see now, and probably eat a little bit also. So those traditional food habits, less carbohydrates, more minerals and white vitamins rich food, diversity of foods, less oil, less saturated fatty acids. I would say those were the golden days of eating. We had our own problems then, but now thinking back, looking back, our food habits, I would say, were reasonably okay than what we have now. Now we have wealth, but we don't have health. Now that's because of food. I would say one incriminating factor is food. Probably next I would say is lack of exercise, but I will blame it on the food for all this sorry state of affairs.
Of course, even in obesity, diet is the main problem rather than lack of physical activity. So I'm going to tell you a patient scenario, and I think it'll be useful to somebody who's listening to this podcast. So I am a medical gastroenterologist in California, so we do colonoscopies frequently as a screening part because insurance covers it when they turn 50. This was a 50-year-old gentleman. He came to me just because insurance covers, he doesn't have to pay anything, so he wants to get a screening colonoscopy. So I asked him, how is your bowel habits? He says, I go to the bathroom once in 2 days. which is normal in many patients. If your bowel habits is 1 and 2 ways throughout your life, then nothing to be worried about. But the problem with this patient is that the frequency decreased only in the last 2 years. And then he came to me, and then we did a colonoscopy. It was a huge cancer right at the rectal area. And as you know, it was very difficult to operate if it was in the rectum. And when we did this cancer evaluation, it turns out that the cancer was spread to the liver, spread to the lungs.
Oh, bad.
It was a stage 4 colorectal cancer. And he passed away in 6 to 7 months. I'll never ever forget that patient, because he's a software engineer working in I can say the company, so he was working in Tesla.
Oh.
It's not that all Tesla patients, it's not like that. It's just that I think what has happened is that the environment pushed him to do stress eating, not be able to manage his stress levels, and obesity was one of the main reason that he put on weight for like 5-10 kilos. All this happened in the last 5 years.
What was the age you said?
50.
Okay.
50. And I see younger cancers as well, but this patient came in for a screening colonoscopy where he didn't have significant symptoms that he thought. So since then, I have always encouraged my audience who is listening to this podcast that constipation is a symptom that we should take it seriously. Do you feel like that in your practice?
Absolutely. And lot of misconception. I would say there are 2 areas where people are misconceived with regards to the symptoms and the disease. One is jaundice. I think, Pal, we can have a separate podcast for jaundice. Yes. But constipation, yes, you're right.
No, please mention about jaundice as well, briefly.
Jaundice is also, again, a sign. It's like a headache or a fever. It's a sign which brings us to the feeling that something is not wrong in our body. Jaundice can be for various reasons. It can be liver problem, pancreatic problem. It can be a cancer, underlying cancer. So we have to go to the roots. Jaundice is a symptom. Likewise, constipation, we have to understand that it's a symptom. It's not the disease per se. Of course, it can be a disease per se when we rule out all other diseases. You would have seen IBDs, IBS, irritable bowel, or cancer. If you rule out the underlying cause for constipation, then we treat constipation as a symptom and as a disease. That's the thing. But I now wanted to make a clear distinction between the symptom of constipation and the disease as constipation. We are worried about the symptom. That's where your role of screening also come into picture. Yes, when somebody walks into my OP and then says constipation, I look at the age, the profile, and then see whether he has got any other disease. But what is worrying me all the time is cancer. So I can afford to delay the diagnosis if it is IBD, if it is habitual constipation, whether he is taking less fiber, all those things. I will not do any harm. But at the same time, if I misdiagnose it to be something else and it turned out to be cancer a couple of months later, I lose that opportunity of 2 months of treating him early. Stage 2 may become stage 3, stage 3 cancer may become stage 4. So that's worrying me. First, any patient. Now, previously, as you rightly said, 50, 60 years patient walking into OP, we thought of cancer. We thought of ruling out cancer. Now, another worrying trend is even at 40, 45 years, if somebody walks in and they say constipation, still we have the mind that this guy can also have cancer. Because cancer, especially colon cancers affecting young individuals, are on the rise. That's again worrying trend. And I'll supplement by saying that those cancers which affect young individuals are invariably very highly spreadable cancers.
Right.
They are very virulent. They spread fast compared to a guy who has got colon cancer at 80, 70 years. They are indolent. Okay, reasonably, I would say, among the GI tract cancers, colon cancer is one of the treatable, friendly cancers.
Correct.
But not so for young patients who has got colon cancer. Yes, I'm worried about constipation all the time. Not that I have constipation, but just we should rule out the cancers in every patient which I see.
Any common mistakes in self-treatment that you have seen in your practice for constipation?
Dr. Pal, yes. There is no, I would say, a real wrong in taking alternate medicines for constipation, provided they rule out the underlying cause.
When you say alternate medicine like homeopathy,
Yes.
Siddha, Ayurveda.
Yeah, Ayurveda. Any medicine, as long as, see, you and me are allopathic practitioners. We don't know how it works, but if a patient says, see, to be fair to all stream of medicine,
Correct.
Dr. Pal, we have to embrace, you have to see the
Benefits of their...
the benefits as well as whatever the science behind it. We have to be fair to all. In that line, I would say that if somebody who is cleared of any disease with regards to constipation, and especially I'm probably the other invisible disease like dyssynergia, ODS, all those things, my take is scientifically you should prove that no disease is there, still patient is having constipation. They are free to take their own medicine, including alternate form of medicine.
I'm going to stop you right there too, so that educate the audience a little bit more. I'm just going to summarize what you said. What you are saying is we need to rule out any obstructive reason or any other medical reason for constipation. If that is ruled out, then you can see any kind of treatment.
Yes.
And one of the causes is the possible obstructive lesion inside the colon, which could be a precancerous lesion.
Absolutely. So my take is, please don't home treat yourself for constipation. And that too in an era of, in 2025, I think we cannot afford to have these kind of things. Dr. Pal, in this, as a cancer specialist, I also wanted to bring to your notice a very important statement. We all read Robinson's textbook
Correct.
of pathology. The first line I still remember, the textbook says, it's very vivid in my memory, the best way not to have cancer is not to be born at all. So all of us have that, because the cells are multiplying. Any one of us, in spite of the fact that we still have very good food habits, we follow organic food habits, teetotalers, we exercise, but still we can have cancer. On top of it, those who deviate from this, they have more chance of having cancers. And we are seeing this incidence. On any day, as not only as a gastroenterologist, but also as a human being, I fear for cancer than any other disease, including heart attacks and stroke. Because that's one thing, that's a slow poison. It's a killer. It brings a little bit of fear even in me. So I think we should really knock off. In that line, constipation, yes, first is rule out cancer. Then it's all in our hands. Now, with available technology, diagnosis, whatever we see as idiopathic, but we neither you or nor me knew anything. Now we could able to diagnose pinpointedly what the patient is suffering from, why he is having constipation. I would say it's a whole new world which is opening up.
So a person listening to this podcast, let's say he is like 25 to 35-year-old, and he is going to the office, he's coming back, he's very busy, but he's having some kind of disturbance in bowel movements. He's coming to you and he's saying that, I think I'm having constipation and I have tried the laxatives already, because the top 10 overprescribed medications in India, in the top 10, 4 are laxatives. Do you see that in your practice?
Yes. In the form of numbers, I would say this is more of an urban disease. Constipation amongst the urban people, that too in the young population who are always stressed. See, with regards to the career, growth, as well as whatever they are in the present scenario. So they have more opportunities. At the same time, they bring more stress. So their circadian rhythm is affected completely. See, we get up early, relax, have a nice coffee or tea, reading newspaper, then go to work, come back, enjoy have some play or games, and then spend some time with the family, relax, chit chat, and then sleep, 7.5 hours sleep. You tell me how many of the sweetie dwellers, how many of you in the 25 to 40 age group bracket are following this, even though they have wealth?
Yeah.
That's the crux of the problem. The crux is because of the pressures and the pulls which an urban life brings, which an urban life is associated with that youngsters, the main thing is I would say more than the reflex. Reflex you can control. GRD is another problem, but this is beyond our control. The constipation. Why I say beyond our control is especially for the listeners, you can push your stools with your effort that contributes only 20% of the effort. The rest 80% is that's happening inside. That is not under our control.
Which is brain-gut connection.
Brain-gut, autonomic nervous system. Something has to relax, something has to contract. It's like a seamless movement.
Can you explain that physiology alone to my audience, please?
Yes. Oh, that's a very interesting.
How does a bowel movement happen?
Yes. See, compared to swallowing is a predominantly our own effort. We can swallow or not choose not to swallow. But unlike what goes in, what comes out is not in our hands. It's all something to do with our surroundings. It all something to do with our brain, gut axis. So that when we are relaxed, when we are at peace with ourselves, this particular thing happens. This shit happens every day. People used to say, sorry to mention that one. But what happens is, it's a very important thing. So your mind and body should be in synchrony when the motion happens every day. So that some of the muscles contract, including little bit of abdominal muscle, the pelvic floor relaxes. So that from there the intestines contract, whereas what holds all, the pelvic floor is the bottom of all of us.
Can you educate the audience, what is pelvic floor?
Okay, pelvic floor is the muscles which are at the base of our torso, our body. Beyond the pelvic floor is the lower limbs, legs. So whatever, imagine your abdomen is like a shelf. The lowermost, the strong layer is the pelvic floor. That holds all the organs which are stacked up, starting from the rectum upwards onto the colon. Then we have the liver, everything are stacked up the shelf. The lower strong layer is the pelvic floor muscle. Unfortunately, that's not under our control. We can move our hands and legs or even face muscles, but the pelvic floor muscles, they work under only when we are at peace. In a case of our daily bowel movement, the muscles above, like the intestines, contract. It has to squeeze in. The pelvic floor should relax. It's a very logical thing. Something has to relax to accommodate the motion which is coming out. So the muscles, the intestinal muscles contract, pelvic floor muscles relax. That's why, and that contraction is aided by our muscles only to the tune of 20%, not more than that. So people think that more you squeeze, more you use, like say I'm a gym goer, I can try to squeeze. It doesn't happen. It doesn't listen. Pelvic floor doesn't listen to you at all. So we can aid in having the clearing the bowels to the tune of 20%. 80%, as I told you, it's a symbiotic relation between your mind and body. You have to be relaxed. You have to be at peace. And more importantly, you have to have that environment to have that particular, your day-to-day activity should be perfect to have that particular, bowel movements daily. Unfortunately, we don't have that thing in our, I would say, youngsters, which are all, whether it office goers or IT field, whoever, the 25 to 40 years bracket is the most sufferers of the lot because of not having this. It can be food, it can be stress, it can be, I would say, the shifts, it can be new environment, anything, but they are suffering.
They're suffering, yeah. So when a patient comes to me with that problem, first what I ask is the fiber intake. As we did a research, actually there is a website that you can go to, happytummy.ashirwad.com.
Oh, that's nice.
And there is two calculators. One is digestive quotient. So you just type in your general habits and then it'll tell you how good your digestive habits are. Second is your
My meal plan.
What they do is you just type in whatever you are eating and it will tell you how much amount of fiber that you're taking per day. As per gastroenterological guidelines, a man should eat 38 grams of fiber per day. Women should eat minimum 25 grams of fiber per day. In Indian database, they have this on the website. 6 lakh people have entered this.
Oh, okay.
And out of this, only 30% are meeting the criteria. 70% they don't have enough fiber.
That's a big number.
It's a very big number. Very, very big number. And in this 70%, 80% of people are sleeping less than 7 hours a day. Similar to what you said.
Yes, absolutely.
Right? The brain-gut connection.
Yeah.
It's absolutely. How do you include fiber in your diet?
See, it's very simple. Make one bowl of fruits every in the morning, preferably in the morning, because you eat like a king in the morning. Have a good amount of breakfast and have fruits. Night, see, and afternoon it's predominantly salad based. You cannot have fruits most of the time. So morning, lot of fruits. Afternoon, vegetable. In our practice, we have a lot of this poriyal sambar. I mean, all those poriyal and all, kootu and all.
Kootu.
See, along with that one, if you don't have, what do you have? You can have salads. So predominantly fruits in the afternoon. It sometimes may not be possible. So I take more of salads and all these traditional. Indian food, which has got a lot of these vegetables. Night, you take more of fruits. There are two benefits having more fruits at night. One is the digestion happens smoothly because if you eat heavy food at night, our gut struggles a lot to digest. Midnight biryani, all those things are whatever that brings us happiness. That's our way of life now is injurious to gut. Right. So eat light and add more fruits. Your gut will be smiling at you.
Yeah.
So that is how we, as you rightly said, why for 40 grams, 50, 60 grams also
it's
you
good.
can take. It's good. So that it's, I would say, morning, that particular action, I would say it should be a symphony.
Symphony, exactly. It's like a musical orchestra.
Absolutely.
Yeah.
Lot of instruments at play are here also. Lot of whether the pelvic floor, our muscles, or the rectum and the other thing, everything should be in harmony. They should play a perfect symphony to get that thing out. Isn't it?
Exactly. Indian patients come to my US clinic. They say that, hey, I'm South India, I'm eating white rice, I love my white rice, what should I do? I said, white rice is okay. But the problem is because it is a refined grain, they're removing the whole grain part. And that is why the fiber is lost. So I sometimes say that, I'm a big fan of multigrain atta. I try this Ashirwad atta and it is really tasty. In US, I always recommend that to everybody. So what they say is, you take white rice a little bit, but don't take white rice alone repeatedly. You can replace that with the chapati, whole wheat roti. 3 chapatis will give you 10 grams of fiber, 9 to 10 grams of fiber, whole wheat. Especially if it is multigrain, then they add soya, chana, maize, oats and everything. That increases the fiber requirement. They meet 25% of the fiber requirement in a single meal.
And without knowing that they are taking the grain, the fiber. Yes. It's like adding the iodine in the salt. Government has made it mandatory.
Exactly.
See, you don't make any additional efforts. What I say is, you take additional efforts to make sure that you have at least a portion of it as salads or fruits. What you're saying is, without us realizing that we are having the fiber, you will have it. That's a very good solution, Dr. Pal. I really, in fact, I should try that one.
Exactly. In our South India mainly, people think that whole wheat atta roti is only for diabetic people.
No.
That is not true. I think we should.
And it's tasty as also.
It's very tasty.
Yes,
it's very tasty.
Yes.
And people say, oh, then you are going against rice. No, it's not the case. I love curd rice. Curd rice tastes better only with white rice.
Correct.
Okay. But decrease that amount and replace the other meal with a multigrain atta or something like that.
Absolutely. That's a good solution. Good and practically doable solution.
Yes.
So that you no need to really search and then do it in the sense wantedly, or you have to put additional efforts to get the fiber.
Exactly.
It happens just like that.
Just like that.
Yeah.
And I want you to go to happytummy.com.
I do.
I want you to write your habits.
Definitely.
And you text me what is your digestive quotient.
I'll do with it. Probably I should pass.
You should pass, exactly.
I should not fill in that 70% category.
Correct.
I should come into 30%, hopefully.
But many doctors are in 70%.
See, doctors are poor patients.
Correct.
Everyone knows. We are poor compliant. We have poor compliance with medicines. We are poor patients. I cannot say it in
the
public
podcast.
forum, but still, facts.
So what I do is, if let's say the fiber, they're not, let's say they're meeting the 25 grams. The second step in treatment of constipation is we add fiber, like psyllium husk, or in the US there's a company called Metamucil. I'm saying all this, but it is not a sponsored podcast, okay?
It's all dried powdered fiber.
Dried powdered fiber. There are two kinds of fiber, right? Soluble fiber, insoluble fiber. Soluble fiber is where it dissolves in the blood and the water and it slows down your digestion. Insoluble fiber is within the intestine itself. It adds bulkiness to the stool.
Correct.
So that hopefully it will come out.
Yeah.
But the problem that what you're saying, sir, is despite adding fiber supplements, despite increasing the amount of water, I feel like the most underrated reason for constipation is that dyssynergy of the beautiful orchestra what you talked about. We call in medical terms as dyssynergic defecation.
Yes.
I want you to explain this complex term to my audience in a very simple way.
See, in this symphony, if some instruments are played wrongly, it's not in tune. Suppose you have percussion which is fighting against the wind instrument, you don't have a good symphony. You don't have good music, isn't it? Likewise, the dyssynergy happens when I told no, some muscle has to contract, some muscles have to contract, and the pelvic floor has to relax. What happens if the pelvic floor muscles also contract?
It will not come out.
It will not come out. They try to compete with each other. In the process, the motion will not come out. All the bowels, they compete with each other. What is supposed to be a symbiotic, coordinated movement, they fight against each other. That's the main problem with this obstructive defecation or dyssynergia. We may call it as in our medical terms, but what happens is there is a complete disharmony between what is supposed to relax and what is supposed to contract. What happens if both of them contract? What happens if both of them relax? That is what happens in obstructed defecation syndrome or pelvic floor dyssynergia. There, Dr. Pal, the fibers will not help.
It will not help.
It will not help.
Exactly.
That brings us to my first point. Constipation has to be evaluated thoroughly. Whether you are having lack of fiber as a result, whether you have dyssynergia as the cause, or whether you have real block like cancer for constipation. You need to figure out. And you can figure out, you and me can figure out with colonoscopies, anorectal manometries, all the constipation studies, hardly three or four studies by which we can find out whether what type of constipation you are suffering from.
Can you educate the audience about anorectal manometry? What is anorectal manometry?
Okay. It's basically pressure studies. We put certain transducers and catheters inside the rectum to see this harmony of contraction and relaxation happens at adequate level. If something is more or something is less, we will find. It's basically pressure studies. See, suppose we measure our muscle strength by way of push-ups and pull-ups, how much we can climb, all those things. Likewise, rectum and the pelvic floor, how much it is working or not. This is a physiological study. It's all pressure. Pressure is the one which pushes, right? So that pressure measurement, how much the pelvic floor relaxation, everything can be measured now with anorectal manometry, a simple test. That will differentiate whether you are having a slow transit constipation, if your gut is healthy, meaning no IBD, inflammatory bowel disease, no twists and turns, no cancers. On the face of it, if the gut is normal from test point of view, still we wanted to go to the physiological level. This anorectal manometry will bring whether your constipation is because of slow transit or because of dyssynergia.
when you say slow transit, it's because of lack of fiber.
Lack of fiber, yes, yes.
Lack of fiber, lack of water is the reason.
Correct.
Or is it because of lack of harmony between these muscles that, as you said, beautifully said, the orchestra. So in my patient population, you will not believe, mainly women, 50 to 60% of patients are because of this lack of harmony
Correct.
and not lack of fiber. And we do anorectal manometries and we identify that, okay, so this patients will not get benefit no matter how much amount of laxatives that we do.
In fact, it will worsen the symptoms.
It worsen.
Yes, because see, laxatives and bulk forming the fibers, that means you are producing more stools. So more residues, meaning the muscles have to push more. Already the muscle is not working. See, already a container is not working. You put in more stuff, and how it work? It will worsen. Somebody, we also do trial and error. If somebody before manometry, if I see that I wanted to check, I provide laxatives and especially bulk forming. If they get relieved, yes, it's because of lack of fiber. If it gets worsened, it's dysenergia.
Lack of harmony.
Yes, lack of harmony.
Yeah. So in my practice in the US, we refer these patients to something called biofeedback. As we were discussing. Okay. So I want you to educate the audience.
Yes.
What is biofeedback in a very simple terms?
Let me explain. So I told that there is disharmony between the muscles which contract and muscles which relax, isn't it? After finding out through anorectal manometry, okay, this is the problem, then we involve some of our physiotherapist, some of it's basically a digital treatment. Why I say digital treatment? See, you are I would say a digital doctor. You have created revolution in the world by by providing lot of information. We are in a digital revolution. Likewise, I can say this biofeedback is one of the medical digital revolution because people need not be there in the lab or with the physiotherapist every time. Initially, they have to learn how to make the pelvic floor relax.
Because it is contracted.
It's contracted. So it's like a form of physiotherapy. When somebody is having stroke, they have to make use of the physiotherapy to bring the muscles back.
Correct.
Likewise, this pelvic floor muscle is already contracting. So we have to educate. As I told you, it's not in our hands. It's a training we have to give. So using the very sophisticated transducers and some vision. See, suppose if you have a stroke, with power we can use our hands and legs. But whereas pelvic floor requires some sort of simulator, some sort of visual things to make sure that we are having a command over the pelvic floor.
By looking at something, you are aware of what is happening inside.
Yes. It's basically we are training our pelvic floor muscles to relax and to contract based on the visual scores. So that's the laboratory training. See, in about 10 days time, they know how to contract, how to relax. It's like a swimming. See, when somebody who doesn't know swimming, in about 10 days time, we learn the swimming.
Correct.
Or driving. Like that, we know how to control the pelvic floor muscles by this biofeedback. Initially, I thought something is different, but once I learned this, okay, this is a form of learning, making our pelvic floor muscles to learn when to contract so that we know. We have a control over the pelvic floor. When somebody pushes, we have through some maneuvers, we try to relax. Already, which we have already trained in that training sessions. And we can practice at home. So that's why I call it as a digital treatment.
Digital treatment.
You learn it in few contact sessions, and then you can go for training yourself for long so that you produce good results.
So in my practice, sir, we see this biofeedback helpful for both constipation and also incontinence when people are having fecal leakage and urinary leakage sometimes as well. So fecal leakage, fecal accidents, you will not even imagine the amount of problem that they have.
It is social stigma.
Social stigma, yeah.
Urinary stress incontinence. Imagine See, that's a big. I've seen people not going out for this, either fecal incontinence. For those fecal incontinence in the sense leaking of motion or leaking of urine. So this is basically a big problem. From medical point of view, it may not really. It's not life-threatening disease. From social point of view, people not going out, staying at homes, glued to indoors. It's a big thing. This is exactly the reverse of what we teach for constipation. We make them contract more. So
the pelvic floor needs to contract.
Yes, so that to have a control. So it's like a gatekeeper. For some, it has to make a real, I would say, gatekeeper, so that it should not allow something. At some point, when something has to go out, it should make way. So that's the pelvic, amazing organ, I would say, pelvic floor.
Exactly.
Muscles.
It is one of the beautiful organs.
Yes. So for fecal and urinary incontinence, we teach the opposite. How to make more, how to make it contract more. In constipation, we have to train the muscle how to relax more. Whereas in fecal incontinence and urinary incontinence, we have to teach the pelvic floor how to contract more. This is again the job of the physiotherapist and the special healthcare providers to make it whether to contract more or to relax more, depending on the situation.
I'll tell you, I've been practicing in the US for the last 15 years, okay, including my gastrointestinal fellowship. When we refer a patient to biofeedback, we don't even know what happens over there. So I'm very glad that my friend, his name is Siva Nadaraja, he found this beautiful device. It's called Jogo Health. I have been referring my patients to them.
In fact, to understand more, I did two things. One, I asked the Jogo people to come over to our hospital. I wanted to see how it works. Really, they brought all the transducers, some of the electrical circuits, and the monitors which we see. And then second time I went to their lab. Because only if we are convinced, we have to offer that treatment to the patients, isn't it? See, if we are convinced, we know the mechanism of action, then the whole set of people who are suffering, we can offer them a new lease of life, isn't it? So for that, I wanted to learn by myself.
So you experience yourself?
Not experience, by seeing.
By seeing.
Fortunately, my symphony is like Ilayaraja's symphony.
Musical orchestra.
Musical orchestra.
Nice.
God's grace, touch wood. It's
let it be like that.
Thank you so much. But for the needy, I should direct them to a proper area.
Correct.
Whether my medicine works or my lifestyle advice works, or it's a biofeedback which works. I have to channelize the patient to where they are supposed to go. For that, I need to understand, and then I understood it completely. And now, in fact, we are the first to cross 1,000 patients in a short span of time. We did a study.
Wow.
And then, like I said, about 70-80% of people, they are quite happy. And up to 90% of the people who take biofeedback, they could able to see the results in about 2 months' time. So no medicine. Advantage is, Dr. Pal, no medicine is involved. It's basically training our own muscle. It's a physiology. So no side effects. No. Only that. Cost is nothing. We just wanted to have training sessions, and the rest all digital. I would say it comes to your area. You can.
How long does it take, sir?
See, I would say, I think 10 sessions of contact we have to visit. After that, in about a couple of months' time, they are on their own. They know they can master. So now, if they can try, initially we have to handhold them. That's what
they have
these
to
people
teach. This is abdominal muscle. This is pelvic floor muscle. You are contracting.
By vision. So when we move our hands, we see ourselves. But when we contract or relax our pelvic floor, nobody sees it. And if you have some visual to train, we know, okay, these are the areas how we contract. It's perception that we make. That perception and that particular training happens with the digital treatment. Amazing technique, I would say.
To be honest, it has revolutionized my practice. I'm telling you, people are so happy.
Right.
And I wish many people
Yes.
has to know the difference between these two, what you said.
And it's the duty of the doctors like us who have to channelize these patients, because nobody can walk into a biofeedback center and then say, I want a biofeedback. That's not the right way. Initially, evaluation has to be proper, and then we select these subset of patients who have disharmony, and then our medicines will not work. Let's confess.
Correct.
It has to be put into this kind of biofeedback, this kind of physiotherapy sessions, so that they get a good lease of life without having to swallow any pills, isn't it?
Yeah, it's really amazing. I hope anybody listening to this podcast, so let's say they're dealing with constipation. So we can summarize what are the things to be done.
But before that, may I ask, will you suggest this one to Arogya Sami or Saravana Kumar?
Of course. Of course.
If they have.
They will have.
They will have. Some Saravana Kumar and some.
If your sleep is less than 7 hours a day, you will have.
Yes.
Mostly. Yes. If you are having ultra processed food, you are going to have. Because the bottom line, sir, whatever it is, your brain gut connection.
Absolutely. Now we talk about, see, I chose, you and me chose gastroenterology, but still our brain is not leaving us in the form of brain gut axis.
Correct. So it's an absolutely, I do research in basic science.
Right.
It's an absolute pleasure to see how the brain gut axis works, and it is so sensitive. It just
You are fascinated, but we as a surgeon, we always cut and paste. We don't see this axis and all, invisible axis. So I believe in cutting and pasting. You believe in the axis. But of course, we have to come together here
for treatment.
in the treatment.
So we can summarize to somebody listening to this podcast. So let's say you have constipation. As you repeatedly mentioned that before trying any other alternative medicine, make sure that there is no medical reason for constipation. In terms of medical reason, there are two options. One is lack of dietary fiber. Second is lack of harmony of the muscles. For fiber, we talked about it, increase of fiber intake, 25 grams of fiber, and you said that you give a trial to my patients if they are reaching the fiber intake, and if they don't get better, then you know that it is not the lack of fiber, it is a lack of harmony. Then lack of harmony should be evaluated by an anorectal manometry to identify the pressures and then referred to biofeedback. Is that something that you agree?
Beautifully you put it. You summed up very nicely, as usual, as always.
As always. And biofeedback is something, it's a physical therapy. It's like a stroke patients, how you get physical therapy. It's a physical therapy for your anal sphincter muscles.
Correct.
It is absolutely wonderful. I'm so glad that if somebody like an expert like you coming on the podcast and telling my audience about the steps in treatment of constipation, I hope somebody listening to this would really get benefit out of it. Before I leave you, I wanted to ask you one important question where, as a cancer specialist or seeing gut health thing, what is the one thing that you wish a patient listening to this podcast will get better?
Eat well, eat healthy. That's the crux of the problem. I may add, sleep well as well. Eat well, eat healthy, and sleep well. Being a gastroenterologist, if any one of the viewers listening to this podcast wanted to make us jobless, they have to eat well, sleep well. Because 75% of the diseases, gastro-related diseases, are food-related, stress-related, and sleep-related. If they can try to overcome this, we will be left jobless. And that's what we want, isn't it?
Yes.
On the larger interest, on a serious note,
Of course.
gut health is very primary for our general well-being. And we live in an area, in a time zone where food plays a major role, and that is contributing to up to 75%. I repeat, up to 75% of any gastro-related illnesses. So maintain your gut harmony. You will no need to see any physician or doctor in your lifetime, isn't it?
Super. Wonderful.
That's my message.
Wonderfully put.
Leave us jobless.
That's really nice. That's why they call this a noble profession.
Correct.
Yes. Thank you, sir. Thank you so much for your time. It has been wonderful. Best wishes for your successful journey. You're already successful. Keep saving many patients, and thank you for your time.
And from my side, continue the good work of enlightening the people with your podcast, with your message, which is reaching far and wide. I'm very happy. I've seen you growing from a medical student.
Yes.
Yes. I mean, when I was just coming out of MBBS, you're just entering. So since then, I've seen you growing. Yes. Keep up the good work. Keep up the, all the awareness messages, because reaching now, we have the informations available are plenty. We need to channelize which is good and which is bad.
Right.
And you're doing a good job. Continue the good work, pal. All the very best to you.
Thank you so much, sir. Thank you so much for your time. Thank you. Thank you.